Well, that was quite a morning. Just fascinating presentation. So my name is Tom Brunner, and I'm the president and CEO of the Glaucoma Research Foundation, and I want to thank you all for being here for this first annual Patient Summit. This session, we're going to hear from both doctors and patients about how to create your own A-team for your care. Since glaucoma is a lifelong disease, it's important to have clear communication with your eye doctor and make sure everyone in your care team is aware of your glaucoma. So with us today, we have my colleague and the chairman of the board of the Glaucoma Research Foundation, Dr. Andrew Iwach from the Glaucoma Center of San Francisco, and Dr. Sidney Williams, a longtime friend and associate from the University of California, San Francisco. And we also have 3 glaucoma patients, Amanda Eddy, who you heard and met earlier, and Stephanie Handler at the end, and Beckys Vilendrer. And Stephanie, I think you were first diagnosed in your 40s, early 40s, and Becky in your 30s, I believe. So we're going to get a chance to hear from everyone, and I have some questions which I'm going to put out to our panelists, if you will, and then we also will open it up to your questions. And I was going to ask both Sid and Andrew, what advice do you have for newly diagnosed patients?
I think that for you as a patient, you have to gather a lot of information when you get diagnosed with glaucoma. And the first thing when you tell someone that they have glaucoma or might have glaucoma, the first thing that comes to mind is that they are certain that they will lose their vision and go blind in their foreseeable lifetime. And it's the doctor's job to address that issue before they leave the office that day, on the day of the diagnosis. But any newly diagnosed glaucoma patient needs to have a lot of information. Most newly diagnosed glaucoma patients have no idea that they're sick. They feel completely fine. They're shocked to find out that they have any problem at all with their eyes. Some patients with advanced disease do know something's wrong, but most don't know anything's wrong. So in order to commit yourself, and this goes to what I'm going to talk about later, to therapy and drops and treatment, you have to believe that you have something wrong. You have to understand this disease, and it's complicated when you're completely asymptomatic. So I think the newly diagnosed glaucoma patient needs to get a lot of information. Hopefully the doctor will provide it that first day. If they don't provide it, they need to look things up and ask a lot of questions. I think the real key for any glaucoma patient, because it's such a complicated disease and there's so many stages, is to get involved with your care actively. Don't be a passive patient. You want to be an active patient. I'll just stop there.
Thank you. And I can't emphasize enough, and you're going to hear from our patients. I think your last comment was incredibly important. Andrew, tell us what you discussed with your newly diagnosed patients.
So I know that when they hear that word, they are scared because they're thinking they're going to lose their vision. The most common types of glaucoma, in general, we can keep you seeing. It moves slowly. And as we'll talk about later on, there are going to be different inflection points in your management of this lifelong issue. Do you have glaucoma? Are you at a higher risk for glaucoma? How are we going to manage that? So at that first visit, we need to get a sense of where you are, and you have some time to think it through, to consider options. And it's really important that as you look at how you want to manage this issue, that you are starting to think, what's going to make sense? How do I develop that partnership that Dr. Williams talked about? Because you're going to have a coach. We're going to be working on this together, fighting to keep your vision. But take a deep breath, because we don't win all the battles, but we win most of them. And so we need to figure out what's the right way to help you. And that's a complicated question.
Thank you. So, Stephanie, I want to go to you because when you were first diagnosed, I don't think you actually believed them. And so tell us a little bit about what you did when you heard that you might have glaucoma, and how did you deal with not really liking that diagnosis?
Sure. Well, first of all, I just want to say that I'm very grateful to be here today, and congratulations to the foundation for having such an amazing patient turnout. I think I was one of those people that a visit to the eye doctor had taken a back seat because, and ironically, I worked in healthcare for a very long time. But when I first went in for an appointment, I thought I was just getting a standard eye check after not having one for a period of time that I don't even really care to admit. But I went in, I was told that I have glaucoma, and incidentally, I was diagnosed by Dr. Williams, who was fantastic, and I'm so grateful to both the foundation and him for teaching me about this diagnosis and allowing me to kind of embrace it. I'd say that, I definitely was shocked. I think any of us could say that, especially if we're diagnosed later in life, that you think your vision's fine, and then you go in and you learn that it's not. And my left eye was so severely damaged, the optic nerve, but I didn't know until my vision was affected. So fast forward to today, it's been 8 years and I've been on 4 eye drops, and the pressure is well controlled. But I'd say the best advice I can give to newly diagnosed patients, especially later in life, is to come to terms with it in whatever way you can. And for me, it was just gathering as much information as I could, to Dr. Williams' point, and also just being comfortable and not being afraid to ask your doctor questions, because the more information that you gather, I think the more comfortable you might be with the diagnosis.
Thank you. Now, I think you told us you also went to an interesting website for information.
Yes, of course, glaucoma.org.
This is an unsolicited plug. So.
I'm thinking the majority of you, how many of you have been on glaucoma.org? Okay, great. It's wonderful information. You can subscribe to the newsletter. It can be mailed to your home, or you can check out the newsletter online. And it's just invaluable information. And actually, day 3 of my diagnosis, I live here in the city, actually knocked on, I don't encourage this, but I knocked on the foundation's door because I really just needed information. And ever since, for the past 8 years, I've been a very active volunteer, and I'm very grateful to the staff at Glaucoma Research Foundation.
Thank you. So, Andrew, if I could ask you another question. Why is it important for patients to share their glaucoma diagnosis and treatment plan with their other doctors, with their healthcare team?
That's a great question. And it's, we think about the eye in isolation, but it's just part of the rest of our body. And actually, the eye is the only place in the body where, without doing an incision, I can see a bare artery, nerve, and vein. So we're in a position to kind of get a sense of potentially some other medical problems. As we look at different interventions, as was mentioned by Dr. Katz, for example, a beta blocker, an eye drop that is commonly used, can actually affect your heart rate, it can affect your breathing. But there's another thing that changes, and that is we all get older. And for example, a drop may have been fine when you were younger, and as you get older, you don't realize it. And the subtle thing, for example, again, using the beta blockers as an example, is it's like one of my patients said, my get up and go got up and left. And I actually sometimes will even talk to the family members, because when it's most dramatic is when we do surgery, laser surgery or incisional surgery, and we remove some of these medications. Another person all of a sudden is seen there. So with that, I encourage our patients to communicate with the internist so we know what else is going on, what other medical issues. For example, there are some medications that can be used that can actually increase the eye pressure. As was mentioned earlier, the relationship with blood pressure. So it's a team effort looking at how we can help you specifically for you, really customizing the plan.
So, Sid, a question for you. When should a patient see a glaucoma specialist? What should they look for, and what's the best way to find a glaucoma specialist?
That's a good question. First of all, just about every ophthalmologist on their website says they're a glaucoma specialist. So beware. To be a glaucoma specialist, you have to have had fellowship training in glaucoma, which is an extra year after you finish your residency. So beware about that. Be wary. A lot of people say they're glaucoma. Yeah, we treat we're specializing in glaucoma. They're not glaucoma specialists. And there are many capable ophthalmologists, general ophthalmologists, that take care of glaucoma and do a good job. But I think that it's probably a good idea for everyone to see a glaucoma specialist early in your diagnosis and treatment. There are so many patients that are overtreated and mistreated that are diagnosed with glaucoma, that don't have glaucoma, that need to know the real fine points of the diagnosis of glaucoma. It's a tricky thing to diagnose. You go from being normal to glaucoma, and if you're close to normal and very early in glaucoma, you can look pretty normal. If it's obvious, then anybody can tell you have glaucoma. But in that early stage where, and now there's this push for earlier treatment, there are many people that are treated unnecessarily and given a diagnosis of glaucoma unnecessarily. And I just saw a great talk by Dr. Leslie Jones from Howard University that said that in quality of life studies, just given the diagnosis of glaucoma decreased your quality of life. Just having the diagnosis, if you have no vision loss and all that, you've just are told then your quality of life indicators on this test that they do decrease. So it's really important that you know that you have diagnosed the right disease. It could be that you're a suspect. It could be not glaucoma. There are many optic nerves that fool people, and there's testing that we use that get us trapped into trying to make a diagnosis based on a test result without looking at the clinical findings. So I'm a big proponent in early on getting to a glaucoma specialist once, at least once. You don't have to necessarily follow up with them. They might not be close by, but get in and make sure you have the right diagnosis and are on the right track. Secondly, you should see a glaucoma specialist if things aren't going well with who's ever treating you. If your treatments aren't going well, if you feel that your eyes are being bothered by your treatments and the doctor's not listening, if you feel that your vision is getting worse and you've been mentioning it but it hasn't been heard, I think you should definitely see a glaucoma specialist at that time.
Yeah, those are all really excellent points. I wonder, Andrew, that the whole idea of when to get a second opinion is kind of what we're talking about. Do you have thoughts on that from the patient perspective? When is it important to maybe get another opinion?
I'm smiling because if you have an inkling you need a second opinion, that means you need a second opinion.
So if you're thinking about it, you better do it.
That's it. And I think there's also, and this is a long-term disease. You're developing a relationship with someone over the long haul. And we all have different personalities, different styles, so you kind of have to find a match that fits and works for you. But you have the right to ask for a second opinion. And if you're in a situation where you're afraid to tell your treating doctor that you're going to do that, or if the doctor gets mad that you want to get a second opinion, that is something you need to take into account. Because really, we collaborate together. We're here to keep you seeing. And if one of my patients said, hey, you know, we want to do something, no problem. We're going to help you get the records, because the more people who get involved to help, especially, most times you don't need it, most is pretty straightforward, but we need to work together. And so I think that as Dr. Williams was saying, I think at inflection points in your treatment, that is when you make that diagnosis, do you have it, how aggressively? One of the big things we look at is life expectancy. We treat someone who's younger that we know we have to see, keep seeing for many more years versus someone who comes in who's 90 years old. If, God forbid, you develop a bad cancer and you have 6 months to live, we're going to treat glaucoma very differently. In fact, that's happened in my practice where a patient, called and said, I'm not going to see you anymore. And I thought maybe we had done something wrong, and she was just saying goodbye. And she wanted to know whether she could cut back on the drops. I said, of course. So those are kind of the concepts we look at. We look at it's an active, changing environment with each patient. You have to communicate. If you feel like you need a second opinion, go get it.
And let me just add, if your doctor is possessive of you, get another doctor. They should be encouraging second opinion. If you bring that up, they should encourage it highly.
It's a flag.
Yeah, it's a flag if they say, oh no, I got this, or you don't need that, or they should be no possession of a patient. It's your right to see whoever you want, whenever you want. And your medical record is your
record.
Medical record. It's not their medical record.
I'm going to ask Becky next here, because you've had to be your own advocate for care for many, many years, and in a way have found other doctors to see. And so I think being your own advocate for your own health and not just your glaucoma, but your whole system. Could you talk to that a little bit about your experience and how you have been your own healthcare advocate?
Sure. Well, I found out that I had really high intraocular pressure when I was in my very early 30s, I think 31, 32, so I was pretty young. Didn't run in my family. I had no idea what it was. And my readings were 25 and 26. I just went in to get a new pair of glasses. So I was really surprised. But the good thing was I was diagnosed before I had any damage. So that has been really key, and my prognosis was that it was caught so early. And for many years I was very stable, and I would go in to see the ophthalmologist in Minneapolis every 4 to 6 months. And he did the series of tests, the OCT, the visual field, and I was very stable. And then maybe 8 years ago, I suddenly had some small amount of damage. And so they were watching me closer, and I went on several medications. And I think I was told then at that time, even though my eye pressures went down, and they at that time were very, very high, and they went down into the mid-teens, but the progression continued. And so that was when I started reaching out for additional help, because I wanted to ensure, I was still pretty young, and I wanted to ensure that I was going to be able to continue to see. So I listed 5 ways that I've been an advocate, and I'll quickly go through these. But one is that I have worked to understand the technical aspects of these tests. So for me, the visual field test, I don't have any visual field damage yet, even though I've had this for 25 years. And so the doctor tells me I haven't had any progression, and that's great. But the OCT test, the optical coherence tomography test, also shows structural damage. So that can show damage before you have any functional visual loss. And that's where I have had damage, fairly significant in one of my eyes. And so I go in, and the doctor gives me those tests every quarter. And I can see with the Zeiss test, there's a progression analysis, and you can see exactly how you're progressing. So I've learned about those tests working closely with my doctors, so that I know what my rate of progression is. The other thing that I've done is the doctor early on had me take one of these diurnal pressure tests. So I went in every hour during the day, started early morning and went through the end of the day. And I know they also can do them throughout the entire night. I haven't done the overnight one, but they measured my pressure throughout the whole day, and mine actually jumps around very significantly if I'm not under control with appropriate treatment. So I was seeing jumps in my eye pressure of over 10 millimeters of mercury during that day. So what my doctor told me was make sure that I go in to get my eye pressure checked on my regular visits during the high point, which for me is the early morning. So I try and get an appointment in the early morning so that I know how high my eye pressure is, and also so that it's a good comparison over time, because mine is jumping around a lot. Although now on the medicines that they have me on, it has stabilized and that range is less. But that was really important, was to understand how that was jumping around. Thirdly is, I learned that I have both really high eye pressure, because they told me I likely have juvenile glaucoma, so it can get up into the 40s without treatment. So even though it typically progresses slowly for people, in my case, I'm just guessing, but from what I've seen, if I'm not being treated well, it can go relatively quickly. So I can see damage relatively quickly because it can go so high. And so I'm really careful. I don't ever forget putting my eye drops in. You know, if I think there was an air bubble in it, I give it another drop. And it says on the side of some of my drops that it should be this temperature range. It can't get too cold and it can't get too hot. And I'm really careful about that. If I go on vacation, I don't put it in my luggage that's going underneath the airplane and it could freeze. I just want those drops to be working for me. And I also am really careful about my appointments so that I don't miss them. And even if I get really busy, I recently, they stabilized me and my progression stopped. But just recently, after 6 years of very stable readings, the eye pressure in one of my eyes jumped up into the 30s with on the strongest medications. So that just happened right before the holidays. And if I wouldn't have gone in for that regular reading, I mean, I didn't think it was going to be any different from any of the last 6 years where I'd been going in every quarter, and all of a sudden it was super high. So it's really important that I found that, because I did have damage on the OCT, but it was only a couple months worth of damage. And if I wouldn't have gone in for that appointment, it could have been really a lot worse. And then I also work closely with my ophthalmologist. I had a doctor in Minneapolis that I saw for 25 years. He just retired, so I found a new one in Minneapolis. But he also encouraged me to go see Dr. Katz at the Wills Eye Hospital, who you guys all heard speak earlier today. And I try and see him at least once a year. And he prescribes a plan for me, which is really helpful. He says, we're going to try X, and we're going to do it for this period of time, and if that doesn't work, we're going to move on and we're going to do this. So I always know what is coming, I guess, which is helpful. And in March of 2017, he told me I needed the SLT surgery on my right eye, and I was scared. I really didn't want to get eye surgery. I really didn't want to get it. And it was borderline. They showed me all the data, and I thought it's a borderline progression. And so I waited. But he was, of course, right. And I just got that surgery probably 8 weeks ago. He did it for me out in Philadelphia, and it worked great. It worked really well. But because of that spike that I had, I did lose some microns of retinal nerve fiber thickness. So I did have an issue that will cause some damage over time. So I shouldn't have been scared, and I should have just done what he said, because of course he was right. And then the last thing, I guess, is I heard earlier that the relationship between eye pressure and blood pressure was discussed. And in my case, in addition to the really high eye pressure, I also have naturally really low blood pressure. Like, I go in for a exam and it's 90/60. I could be totally stressed out and running around, and that's like about as high as it gets. And So that was something that needed to be considered in my treatment as well, because I did have low ocular perfusion pressure. I actually went to see a doctor Dr. Katz referred me to a specialist in Indianapolis, and I had blood flow tests done on my eye. So that is, something that I did as well. So those 5 things I think have helped me. And again, working really closely with my doctor, and I should also add a disclaimer, I don't want to give any medical advice because I'm just a patient, but these are steps that I did working with my doctor that I think have really helped me.
Thank you for that. Yeah. So I wish I could say that I'm as much of an advocate for my health care as Becky is, but I think it's a great example of how getting involved in your health care and seeking out the information you need can really help. So I'd like to, Amanda, maybe you could expand a little bit on how you work with your doctors, because you have certainly literally had a lifetime of living with glaucoma. And could you share a little bit of how you deal with your glaucoma and your doctors?
I mentioned earlier the doctor that did my surgery when I was just a few months old. I saw him for 20 years, all the way up to when he retired. And my family was so sad. We're like, no, we love you. You build this relationship and bond with your doctor because you put so much trust into them. So finding a new doctor was a challenge. I moved to a new city. I was going to college, and we found one that we really trusted and we really liked, and I've been seeing him ever since. So I think finding a doctor that you really have like a great relationship with, you aren't afraid to ask questions. We go in and we get our pressure reading and all the other tests, and then they're like firing off all these numbers to the nurse that's in there, and I'm like, what are you talking about? But being able to ask questions and really understand what's happening in that exam room, because you only see them every 3 to 6 months, or maybe once a year. So that's really important. And then just echoing a lot of the sentiments that have been said up here, but just being an empowered patient, really understanding what's going on with your eyes, because this is a lifetime, that you're going to be dealing with this. So the last thing I would say is really trust the process and trust your treatment regimen. Put your eye drops in diligently, like you said with the air bubble. Like I do the same thing. I'm like, got to get another one in there. But make sure you don't miss your appointments. Just do everything like clockwork, and usually it works really, really well.
Stephanie, you want to add anything? Or?
Well, I actually had a question for Becky. That was great what you had to say about being an advocate. You said the SLT surgery went well, and you had it 8 weeks ago. What do you mean it went well? Like, did your prescription plan change? Did your vision?
Well, so at the time, like I mentioned, I had been really quite stable for 6 years, and then suddenly right before the holidays, I found out that in one of my eyes, even on these strongest medications, my pressure was in the 30s. Mm-hmm. So one thing that I learned is in the future, I'm not going to make any of my appointments right before the holidays. I thought I was fine, and right before, like the week before, I found out that I had, this serious problem. Mm-hmm. And so and I was at the point where there weren't any other medication options that I could take mm-hmm. For side effects or various other reasons. Mm-hmm. And so that was the next recommendation that Dr. Katz had for me. So I flew out to Philadelphia and he did it. And they also did switch a medication, I should say. Okay. But my eye pressure went down from the 30s and now it's in the low 20s or 19. So it really successfully brought it down.
Okay. I figured some people in the audience might have that question, so I just was very curious.
Okay.
But, yeah.
Also, it was easy, right?
Yeah, it really was.
Yeah. Don't be scared of SLT. It's a very, very safe, easy treatment if your glaucoma is out of control.
I would say, I totally agree with Dr. Williams, and there are certain types of glaucoma where we don't necessarily do the laser treatment, but when people hear the word laser, they're thinking about military applications. This is, it just applies a little bit of energy to the outflow tract, and I call it kind of, it rejuvenates it. It gets it to work a little bit better. It doesn't always work, but not always the right answer for every patient. And again, in general, there are times when we have to rush into the operating room, but in general, we have some time and to collect data and essentially to develop that trend analysis where you get one data point, second one you get a line, third one you start getting a trend. And so we really want to, again, usually it's the case, not always, but when we have that opportunity to collect the data, because there's noise in the data as we collect it on all the different tests. So we really want to confirm that the pattern is real before we decide to make some type of an intervention. And one of the suggestions is if you do get opinions, or if you want to have different people involved, there's benefit to having one test center. And I tell patients, wherever you want it, just to have all the tests done so they're on the same server, so they can run through the same software to do. So we leverage the available software for analysis that helps us interpret the data. And then if you do go to other specialists, boy, do I like it when a patient comes in and it's organized it. We look at the patient, but we analyze data right eye and left eye, put it in chronological order. And that makes it a lot quicker and easier for us than to kind of pick things up. If you don't do it, we'll do it, no problem, we'll take care of it. But it makes it a lot easier when if you have the time and you have the actual data ahead of time, that'll speed things up for you.
And I think, Becky, you even plotted out, right, for your retinal nerve fiber layer thickness. She's looking at the slope of the curve herself. So.
Well, yeah, I did do that.
Yeah.
And I think that's great. And I think that at the same time, I think that there are times when it's just a mystery. We're just trying to figure out what the heck's going on. And that's when you start going into these other more sophisticated analysis. For most patients, with the tools we have, partner with us. You have to be with someone who you feel very comfortable in asking questions. But at the same time, we're going to work together, but we're going to work as a team, but we're going to help guide you in this. It's okay to sometimes also let go of a little bit. That is, our job is to keep you seeing, but also we want not to burden you too much. There are times when we got a problem. We got to figure this out. But on many patients, we're going to find that smooth air. Enjoy the ride. If we hit some turbulence, buckle up, and we'll get through it.
Good input. So I have some questions from our participants, and Sid, here's one, if I may direct it to you. If a patient can't remember whether or not they took their drop, what's the best course of action? Should they take it when they remember, when they think of it, or should they wait till the next scheduled time?
That's a really good question and such a common scenario, remembering whether or not you took your drops. I'm a believer that if you don't think you took it and you remember it, take it. It doesn't hurt to take it twice. So probably it hurts more to not take it than it hurts to take it twice. So I would say take it when you remember. But we all have these phones and things now. One of the issues about compliance is just remembering to do it. Set your phone, put an annoying alarm on your phone and let it go off and remind you. Many drops can be carried around and they can be used pretty easily even out in public places and social events. But I'm a big believer in minimizing the drops. I want you to use as little drop as you need to control your glaucoma. And that I think we have to work very carefully with each patient for, because we know from studies on adherence that even when you have one drop to take once a day, at least probably more than half of us human beings don't take it correctly. And we miss a lot of drops like that. And so that's with one drop once a day. So this is a very important thing to talk about. It's important to understand the disease before you have any symptoms and when you have no idea that this disease can actually cause these problems that Becky was talking about. You can destroy your optic nerve and you're completely unaware of its process. It's a slow disease, so we do have time. As Andy mentioned, we have a lot of time to make decisions in glaucoma, and so it's not a quick disease, it's a slow disease. But still, take your drops and work with the doctor to get drops you can afford. I worked with Stephanie early on in her diagnosis, and we made a video together of how to instill eye drops, which is still out, available on the web. Maybe you know the website, but I'm not sure where it is.
Glaucoma.org.
It's on glaucoma.org. Of course. But it's a pretty good eye drop video to show you how to take eye drops, and you can always practice with artificial tears.
Andrew, maybe you want to add a comment on taking drops. You have some tips for patients.
So there are lots of ways to do it, and early in my career, I talked to one of my colleagues who's an eye surgeon but specializes in eyelids, and to get some advice on that particular issue. And what I learned, and he confirmed, is that when you blink is when there's a dynamic that takes tears from our eye towards our nose. If you cry, that's why your nose runs. And the importance of that is twofold. One is that is going into, it's not staying near the eye. Number two, that's how you increase the risk of side effects, because in the nose there's this mucosa, this tissue that absorbs these drugs. And he pointed out that it was the blinking that actually had a very important role in doing that. And so I know that there are different techniques, what they call punctal plug, and so that you try to plug, but actually just keeping your eyes gently closed for a few minutes actually probably works as well as any other technique. Because when I've asked patients to show me how they're doing it, it's quite creative. And so that's one thing. Then I've had another common question: how do I get the eye drop in? I just can't do it. Anyone can get an eye drop in. You lay flat, you close your eyes, you put the drop on the inside corner, and as you open your eye, it rolls in. So if you ever get to a point where you just can't get the eye drop in, that's a fail-safe technique that you can at least get the drop in and then close your eyes for the, how do you know it's 5 minutes? Well, you can set a clock, or you can listen to 2 songs on the radio, and that'll usually do it. And each of these is all alternatives. And the other thing that we're trying to do is find, as Dr. Williams was saying, is we don't want to burden you unnecessarily. We don't want this disease taking over your life unless there are times that it has to. So we want to design a way to help keep you seeing while at the same time minimizing the impact on your ability to do things you like to do today.
One thing I like to do is time the drops with something that you do all the time. So maybe, eating dinner. Prostaglandin drugs are kind of unstable, so I like you to refrigerate at least one of them. Latanoprost or Zalatan, it's kind of an unstable one. I like that to be in the refrigerator. So people like to use it before they go to bed, and that was the recommendation, but it doesn't matter. You can use it at dinner time because you're near the refrigerator then. So sometimes just timing the drops with something that you're doing. If you're taking 2 times a day drop, don't take it when you wake up and go to bed. That's incorrect, because it should be about every 12 hours. So maybe take it before breakfast and after dinner. That's closer to every 12 hours. So things like timing them with activities is also important.
So this has been, I hope, informative. I think some great information. Thank you all very, very much for sharing the knowledge and your stories. And I think with that, we will conclude our session.
Thank you.
Thank you.
Thank you.
Thank you. Thank you, Tom.
Thanks, Tom.